Pectus excavatum. It is the most common type of congenital chest wall deformity, followed by pectus carinatum, cleft sternum, pentalogy of cantrell, asphyxiating thoracic deformity, spondylothoracic dysplasia. Pectus excavatum occurs in 1 in 300 to 400 births with male predominance. The condition is typically noted at birth, and more than 90% of the cases are diagnosed within first year of life. Worsening of the chest appearance and onset of symptoms are usually reported during the rapid bone growth early in the teen years, and many patients are not brought to the attention of the pediatric surgeon until the patient had family notice these changes. The appearance of the chest can be very disturbing to the young teenagers, and the problem with self-esteem and the body image perception are frequently reported by the teenage patient. Pectus excavatum, the growth of the bone cartilage in the anterior chest wall is abnormal, typically affecting 4 to 5 ribs on each side of the sternum. The appearance of the defect widely varies from mild to severe cases, and some patients present with significant asymmetry between the right and left side. The exact mechanism involved in the abnormal bone cartilage growth is not known to date, and the genetic defect is directly responsible for development of pectus excavatum. Despite the lack of an identifiable genotypal marker, the familial occurrence of pectus deformity is reported in 35% of the cases, more often associated with Marfan syndrome and Poland syndrome. The effect of pectus excavatum of respiratory system are varied, and both spirometric measurements and airflow out of the chest on exhalation and plethysmography are usually reduced by 10 to 15%. Children are otherwise normal airways and lung parenchyma. The sole physiological explanation for decreased spirometry values is the chest wall malformation, as these and otherwise healthy patient could concurrent pulmonary disease and pliable chest wall and huge physiologic reserve. The abnormal respiratory function is the only unmasked from the formal exercise testing. Patient with recurrent PE and significant restrictive lung disease, the pattern may be present with the spirometric values as low as 50% of the predicted value. The hemodynamic effect of pectus excavatum are controversial. The direct cardiac compression may result in reduced cardiac output due to reduction in stroke volume. The degree of the severity of the pectus excavatum, however, does not correlate directly with the functional impairment. In some pectus patients, the deep chest and the heart may never be compressed despite several external depressions. Improvement in the cardiac functioning, including the ejection fraction and the right ventricular systolic and diastolic indices, have been reported both in the early postoperative period and the long term following the surgical correction. Mitral valve prolapse is the direct result of the cardiac compression and more prominent than the age-matched population of the 17%. The dysarrhythmias include first-degree heart block and the right bundle branch block, and the Wolff-Parkinson-White syndrome may be present up to 15% of the patient. Congenital heart disease is present in 2% of the patient. The radiological features of the pectus excavatum: the chest radiograph may demonstrate a concavity of the anterior chest wall. Computerized tomography and the magnetic resonance imaging, however, are better in demonstrating the bony and cartilaginous deformities with cephalocaudal extent of depression. Radiological imaging is also important to aid planning of the surgical intervention. The Holler's index. The Holler's radiographic index is defined as the internal lateral transverse thoracic diameter divided by anterior posterior diameter, shortest distance from back of the sternum to the front. Haller's index of more than 3.2 represents severe Pectus excavatum. There is no conservative method has been described for the treatment of Pectus excavatum. The severe disease surgery is required in cosmetic and psychosocial issues, symptoms including those of the reduced lung function, cardiac compression and valve dysfunction. Surgical options include the Ravish procedure, modified Ravish procedure, minimally invasive NUS procedure. Timing of the surgical intervention, however, remains controversial. Performing a NUS procedure before the pubertal growth spurt may necessitate the replacement of the bar as the patient grows in prosthesis. The normal age of repair is 14 to 18 years of age. Modified Ravish procedure. The access is obtained by a transverse incision made by the deepest point of pectus, subcutaneous pectoralis and rectus flaps. Subperichondral resection of the deformity costal cartilage is performed, and transverse sternal osteotomy is then made at the level of the interspace between the uppermost resected costal cartilage to achieve the desired tension-free position of the sternum. Anterior fixation of the sternum is achieved using the metal bar plate or other material. The repair can be reinforced by attaching reapproximated muscle flap. Subcutaneous and submuscular drains are prior for the procedures. The principles of NUS procedure. The most depressed part of the sternum is identified and marked for the placement bar. The template is then fashioned to push the sternum to the desired position. The correct length of metallic bar is chosen, usually one size smaller than the template, and bent to shape the fashioned template. Skin incisions are made anterior axillary line, and a subcutaneous or occasionally subpectoral tunnel is made to the pectoral ridge. Thoracoscope is inserted on the space below and right side incision. Under direct vision, the trocar is placed through the right incision and tunneled into the chest beyond the pectoral ridge. Trocar is used to dissect the plane between the sternum and pericardium. Tape is tied to the trocar and passed to the other side. Tape is used to guide the inverted pre-bent bar, and the inverted bar is then tunneled 180 degrees. To prevent bar from rotating, it may be held in place on one or both sides by stabilizing plate. Occasionally, a second bar is used to achieve better result in older patients with wider deformity. Air from the pleural cavity is expelled from the thoracoscopic incision prior to extubation. The insertion of the epidural catheter for the analgesia is advisable as the stretching of the chest wall is painful. The bar is usually left in situ for approximately 3 years before removal. Complications of the NUS surgery including pneumothorax, pneumonia, wound bar infection, bar displacement, bar allergy due to nickel. The successful Pectus surgery should have following things: the relief of the cardiac and pulmonary compressions, adequate pain management, length of hospital stay, time to return to normal activity, duration of the daily medications, and physical appearance. The Ravish complications is collapsed lung, inhibited chest wall growth, urinary retention, and dissatisfied